Bismillahirrahmanirrahim. Quote of the day: the best among you are those who have the best manner and characteristic and character. Today, the topic of presentation is measure of morbidity. I am Dr. Rabbia Iqbal, PGR Community Medicine, presenting under the supervision of Professor Dr. Saira Afzal, who is, this, who is the Dean of Institute of Public Health, Lahore. So, learning objectives of today's presentation are introduction to the morbidity, distinguish between different measure of morbidity, incidence rate and attack rate, point and period prevalence, comparison between incidence and prevalence, and the relationship, source of morbidity data, recent update and MCQs at the end. So, introduction to the morbidity. Morbidity refers to any departure, subjective or objective, from the state of physiological or psychological well-being. In other words, any disease, injury, or disability in a defined population. So, disease in which any deviation from the normal structure or function include acute and chronic condition, injury, physical harm resulting from external cause, trauma, accident, occupational hazard, a disability in which limitation in the functioning caused by disease, temporary or permanent, physical or mental. So, what is morbidity and mortality? Morbidity refers to ill health. Population-based measure measured by incidence and prevalence indicate disease burden may or may not lead to death. High sensitivity to disease trend. Whereas mortality refer to death from disease. Population-based measure measured by death rate and case fatality rate indicates severity and lethality. Definitive endpoint often used as a proxy when morbidity data unavailable. So next is the significance of measuring morbidity. First is a disease burden assessment, quantify extent of illness in a community, guide resource allocation, epidemiological surveillance, identify disease trend, outbreak, and emerging health threat. Health planning and policy form the basis of planning preventive program and health services. Etiology and risk factor help identify causal factor through analytic epidemiological study. Evaluation of intervention, measure effectiveness of vaccine, screening and treatment program. International comparison, enable comparison of disease burden across the region and countries. Uh, Next is measures of morbidity. Morbidity is measured by frequency, duration, and severity. So, frequency, how often does disease occur? And measured by incidence and prevalence. Duration, how long does disease last? In disease duration, average time from disease onset to the recovery, death, and chronicity. And disability period, duration of function limitation caused by disease or injury. And number third is severity, how lethal or disabled the disease is, which can be measured by case fatality rate and disability rate. Uses of morbidity measure, disease monitoring, track the pattern of disease over the time within the and across the population. Etiological study, identify risk factor, incidence used in cohort and case control studies. Program evaluation, before and after comparison of vaccine, treatment impact on the rate. Health services, forecast demand for curative and preventive health services. Risk communication, communicate disease risk clearly to the policymaker and public. Research based fundamental numerator and denominator in epidemiological research. So next we will discuss the incidence. Incidence is the number of the new cases of the disease that develop in the population and the risk during a specific period of time. So it includes only the new cases. Pre-existing cases are excluded from the numerator. Population at risk, which is the denominator, people who are susceptible and could develop the disease. Time period must clearly be defined, days, month, or year. Dynamic measure reflect the rate of disease occurrence change with time. So the formula of the incidence rate is number of the new cases in a period divided by the population at risk at midpoint multiplied by constant. So numerator is the new cases occurring in a defined period. Pre-existing cases excluded. Denominator, population at risk at the midpoint of the study. A period K is the constant, which can be 100,000, 10,000, and 1 lakh, depend upon the disease rarity, and unit is per unit time. Next is the cumulative incidence. Cumulative incidence is the new cases during the period divided by the population at risk at the start of the period multiplied by 10n, also called incidence proportion, require a definite study period with a fixed cohort. Assume all the individual were disease-free at the start, followed for the entire period. Risk of losing to follow-up to introduce bias. So the application is used in outbreak investigation and cohort studies. For example, 50 new typhoid cases in a school of 500 at-risk students in 2 weeks. So the cumulative incidence is 10%. Next is the special rate, which include attack rate. Attack rate is the cumulative incidence used in outbreak investigation. It is not a rate in a strict sense. It is actually a proportion. The formula of attack rate is new cases divided by the population at risk multiplied by 100. Next is the secondary attack rate. Proportion of the susceptible contact who develop disease after the exposure to the primary case. Formula of secondary attack rate is secondary cases among contact divided by the total susceptible contact multiplied by 100. Uses of secondary attack rate is measure transmissibility and help in contact tracing. Next is the case fatality rate. Formula of case fatality rate is death due to disease divided by the diagnosed cases per disease multiplied by 100. It is expressed in percentage, indicate the proportion of diagnosed cases that result in death, a measure of disease severity. So interpretation, high case fatality rate, lethal diseases, for example, rabies, which is approximately 100%, Ebola 50 to 90%, low case fatality rate for the mild diseases like measles 0.1, 0.2% in the developed countries. So the limitation of case fatality rate are depend heavily on the case as certain, underdiagnosed inflated case fatality rate, true case fatality rate, difficult to estimate during the ongoing outbreaks. The next is the example of the incident rate. A district has a mid-year population of 50,000 during the year. 250 new cases of tuberculosis were diagnosed, all previously affected. So the step first is to identify the numerator, which is the TB's new case, 250. Second is the denominator, mid-year population at risk, which is 50,000. Step third is the constant, which is 1 lakh. TB is reported per 1 lakh. Next, we have apply the formula, which is 250 new cases divided by the total cases is 50,000 multiplied by 1 lakh. The answer is 500 per 1 lakh per year. Next is the proportional morbidity ratio. The formula of proportional morbidity ratio is case of specific disease divided by the all cases of disease multiplied by 100. Proportional morbidity ratio shows the what fraction of the total disease burden is attributable to a specific condition used when only morbidity data is available. So key point does not require population data, cannot calculate true risk useful for hospital morbidity data. Proportional morbidity ratio greater than 100 represent overrepresentation. So the limitation of proportional morbidity ratio is affected by the other diseases frequency. Next is the prevalence. Prevalence is defined as the proportion of the individual in a population who have a specific disease or condition at a given time or a given period expressed per unit of population. Two type of prevalence, point prevalence and period prevalence. Point prevalence is proportional with the disease at one specific point in a time, whereas period prevalence is a proportion with the disease at any time during a defined period, include cases present at the start plus new cases during the period. Formula of point prevalence is all the cases at a specific time divided by the population at that time multiplied by constant. So data collection by the single cross-sectional survey, prevalence survey or census. Existing cases include all the people currently ill with the disease, new plus old. Time point usually a single day, sometime this week for a short interview. Constant, which is multiplied by 100 or 1000 depending upon the context. Next is the period prevalence. Period prevalence is case at the start of the period plus new cases during the period divided by the average population multiplied by 100. So the comparison of point and period prevalence, time preference in point prevalence single point in the time, whereas in period duration days and years. Nominator in point prevalence is existing cases at one time. In period prevalence, cases at the start plus new cases in the period. Survey type include cross-sectional survey in point prevalence and repeated survey or records in period prevalence. So it is point prevalence is best for chronic stable diseases. Period prevalence is best for episodic and relapse condition. Point prevalence, for example, diabetes prevalence on January 1 and period prevalence mental illness over 1 year. The factor affecting the prevalence, factors that increase the prevalence include a longer survival with disease, increased incidence, better diagnosis, detection in migration of the cases. Factors that decrease the prevalence, high cure rate, high mortality, short duration of illness in migration of health individuals. So next is the incidence versus the prevalence comparison. Incidence is the new cases in a time period, whereas prevalence is the existing cases at a time period. Case include in incidence only new cases included, whereas in prevalence high all in current cases new plus old. So the nature, rate and proportion. In prevalence, it is only a proportion. Uh, uh, Time element per year, per month in incidence, whereas in prevalence point or period. In incidence study type cohort and longitudinal, whereas in prevalence cross-sectional and surveys. Incident best for etiology, risk factor studies, whereas prevalence is high care, healthcare planning and burden. Incidence affected by the exposure, duration of the exposure and latency, whereas prevalence affected by incidence and disease duration. Rare diseases show the very low value for incidence and may be higher in prevalence. So this is a relationship between incidence and prevalence. Prevalence is equal to incidence multiplied by duration of disease. If the incidence stay the same, prevalence increase if disease duration increase. Better treatment, longer survival, prevalence decrease if the duration disease duration decrease. High mortality or rapid cure. Next is the factors that affecting the incidence and prevalence. Factors that increase the incidence include increased exposure to the risk factor, emergence of new pathogen, breakdown of the herd immunity, environmental changes and urbanization, increased susceptibility in the population, poor vector control measure, better diagnostic method. Factor affecting prevalence, increased prevalence by increased incidence, longer disease duration, in migration of cases, better treatment. Disease prevalence, decreased incidence, high case fatality. Short disease duration, rapid cure, out migration of the cases. Next is the source of morbidity data. Sources of morbidity data, notifiable disease registration, hospital record and OPD data, disease register and registries, community health survey, health insurance and claim data, and sanitary surveillance. So, noticeable disease report system includes certain diseases that must legally be reported to the health authority by a clinician and laboratory, form the backbone of the epidemiological surveillance. Common diseases include polio, tuberculosis, malaria, cholera, measles, meningitis, hepatitis, and HIV/AIDS. So advantages of this is continuous real-time data, national coverage, early outbreak detection, and free of cost. Limitation: underreporting, only clinical cases reporting bias, incomplete coverage in the rural areas, only notifiable diseases capture. Next is the hospital and the OPD records. Source: indoor patient registry, outdoor patient registry, emergency room admission, medical record, and discharge summaries. So advantages of this is readily available, inexpensive, detailed clinical information, longitudinal patient data, include diagnosis and treatment outcome. Limitation: hospital-based bias, missing mild and asymptomatic cases, no denominator for the rate, incomplete and missing record, variable quality. Next is the disease registries. A disease registry is an organized system for the collection, storage, retrieval, and analysis of the data on a person with a specific disease or condition designed for a long-term follow-up. So in Pakistan, there is a cancer registry, TB registry, congenital defect and diabetic registry. Next is the Community Health Survey. Pakistan Demographic and Health Survey, the National Representative Household Survey conducted after every 5 to 7 years. National Nutritional Survey assess nutritional status and deficiencies. Sanitary Survey selected sanitary site reporting data regularly. Special morbidity survey done for a specific public health problem, for example, TB prevalence survey, malaria indicator survey. So next is the recent updates. This is an article, a deep insight into the incident, prevalence, and complete epidemiology and predictive association among the multiple factor of breast cancer in Karachi, Pakistan, a cross-sectional survey of 2013. Breast cancer is recognized as a global issue affecting the millions of women with the greater impact on their life. Worldwide, breast cancer is among the most prevalent form of the disease. Throughout their life, 12% of the American um, women will experience a breast cancer diagnosis. And in 2017, more than 250,000 new cases were reported to the medical community. So this study is conducted in a cross-sectional approach retrospectively in a tertiary care hospital in Karachi, Pakistan. Um, the result of this is no significant association was found between the ethnicity and segregate hormone receptor status. These findings suggest the need for intervention such as awareness program, lifestyle adaptation, and more breastfeeding hormonal usage training program to the prevent diagnosis, postpartum awareness and prevention, thus reducing the disease load. Also, unavailability of data highlighted the need of for a centralized national cancer control body promotion and the entry of update data of those patients across the private and the public sectors. Next is the 2-year epidemiology of the post-COVID-19 condition in Bangladesh, a cohort study of the post-COVID-19 between July and December in Bangladesh. The background was post-COVID-19 condition is also known as the long COVID is persistent debilitating disorder that need investigation on their incidence, morbidity, and case fatality rates. So the purpose of this study is the objective of cohort study were to determine the incidence, characteristic, case fatality, morbidity, and recovery of the post-COVID symptoms throughout a 2-year period of observation. The result, the incidence of post-COVID condition was 3.6, the case fatality rate is 1.92, and the recovery rate was 9. The significant predator of post-COVID-19 morbidity were geographical distribution, vaccination, comorbidities, and longer duration symptoms are the multiple symptoms. So the conclusion of the study was the study comprehensively analysis the epidemiology of the post-COVID-19 condition and the occurrence, death, illness, and recovery rate from July to December by utilizing the clinical diagnosis criteria established by the WHO for post-COVID condition and performing the screening in the household across the 8 districts. The study determined that the incidence of post-COVID condition was 3.6, the death rate was 1.92, and the recovery rate was 9. The study identified the important factors strongly influence the occurrence of post-COVID condition morbidity such as geographical distribution, vaccination status, presence of other medical condition, and duration symptom. Next we come to the MCQs. MCQs number 1, a city has a population of 60,000. In 2024, 300 new cases of the respiratory disease were reported. Which measure best reflect the frequency of the new cases in this population? C is the right option. Incidence rate. A study include 5,000 individuals of the whom 125 already have disease, which is the prevalence per 1,000 population. A 5 per 1,000, B 10 per 1,000, C 15 per 1,000, D 25 per 1,000, E 30 per 1,000.
C, delta.
Yes, D is the right option. MCQ number 3, during an outbreak in a village, 30 individuals developed disease within 10 days after a primary case. There were 50 close contact. Which is the second? What is the secondary attack rate? A 20%, B 30%, C 50%, D 60%, E 70%.
D. Delta.
Yes, D is the right option. So this is the calculation 30 by 50 multiplied by 100 is the 60%. MCQ number 4, a researcher want to measure the burden of disease in a city, including both old and new cases over 1 year, which should be used. A, period prevalence, B, point prevalence, C, incidence rate, D, case fatality rate, E, secondary attack rate.
Alpha.
Yes, yes, A is the right option. MCQ number 5. During a monsoon outbreak of a refugee camp of 5,000 people, 400 developed acute whitey diarrhea within 5 days. Which epidemiological measure is most appropriate? A. Point prevalence. B. Attack rate. C. Incident rate. D. Case fatality rate. E. Secondary attack rate.
C.
B is the right option. Yes, B is the right option. MCQ number 6. Secondary attack rate is the most useful for assessing which of the following: A. Severity of disease in affected individual. B. Risk of disease in a general population. C. Transmission among the susceptible contact. D. Overall burden of disease in a community. E. Duration of illness in affected cases.
C.
Charlie. A.
Yes, yes, C is the right option. MCQ number 7. Which of the following best explain why incidence is preferred over prevalence in an etiological study? A. It includes both new cases and old cases simultaneously. B. It reflects total burden of disease in a population. C. It measures the occurrence of new cases over time. D. It is easier to obtain from the hospital record. E. It is unaffected by disease duration change.
C.
Yes, C is the right option. Yes. MCQ number 8. In a hospital, one student were meningococcal meningitis among 20 close roommate exposed to the case. 5 developed disease within 1 week, which is the secondary attack rate. A, 10% among susceptible hospital contact. B, 15% among the susceptible hospital contact. C is 20% among the susceptible hospital contact. D is 25%. E is 30% among susceptible hospital contact.
Delta.
Yes, D is the right option. So this is the solution. MCQ number 9. Which of the following best describe the incident rate? A, total number of the cases present in the population at one time. B, number of deaths due to disease in a given population. C, proportion of individual developing disease over time. D, speed at the which new cases occur in a population. E, risk difference between exposed and unexposed group.
D.
D.
Yes, D is the right option. MCQ number 10. A researcher want to identify risk factor responsible for developing lung cancer among smokers. Which measure would provide the most useful information? A, point prevalence measured through the health survey. B, period prevalence measured during a one decade. C, incidence measured through the cohort follow-up. D, proportional morbidity ratio from the hospital data. E, case fatality ratio among cancer patients.
C.
Yes.
E.
No, C is the right option. Incidence measured through the cohort follow-up. So this is the answer key. This is a YouTube channel where the recording of this presentation will be uploaded. And thank you.
Dr. Rabbia, thank you so much. But kindly, if you can lower the speed, slow down. You are always so fast that it goes. It's hard to understand. So kindly slow down the pace. It's a